Great. I'm hoping to speak for about 45 minutes with some time for questions at the end. So please do write them as we go along, and hopefully we can come to them at the end. Okay, so thank you all very much for coming along this afternoon. I'm going to present some of the work I did in my PhD. As Andrew said, I was awarded my PhD about 2 weeks ago, actually, and I took 3 years out of my psychiatric training to do a PhD between ST4 and ST5 in training. I'm an old age psychiatrist currently doing an extra year in liaison psychiatry. My current university title is Honorary Clinical Research Fellow. So I'll start by talking about the different components of the title, really. So we'll talk about epidemiology, multimorbidity and polypharmacy, and how those can be applied to mental health. So first, describe what multimorbidity is and different ways of measuring it that might be of interest, particularly to those working in or researching in mental health. And then also talk about polypharmacy, and then move on to the results of some of my data analysis, which I conducted in routinely collected NHS Scotland data, and specifically looking at the questions of how polypharmacy increases or decreases the risk of dying with a mental disorder, how it might impact psychiatric admissions, and the impact of psychotropic drug use on mortality. Although obviously this is all epidemiology, so it's mostly descriptive. And I thought I would start with a favourite quote, that epidemiology is more than simple counting, it's the basic science of public health. And I think the last few months of the coronavirus pandemic have shone a spotlight onto epidemiology as perhaps being more important than maybe it had been considered in the last few years. And particularly even descriptive epidemiology can be extremely useful in looking at patterns of disease and how those affect people in the real world, as well as being, as some people would call, the study of confounders. So moving on to what is multimorbidity. This is the point where I normally ask the audience, I'll just talk to myself. I'm mostly going to talk here about the difference between multimorbidity and comorbidity. So in multimorbidity, that's the term that we use in clinical research, really a shorthand for multiple chronic conditions. And multimorbidity refers to a patient who has multiple chronic conditions where there is not a specific index condition or one particular condition that's considered any more important than the others. So it's really looking from the patient's perspective, or the doctor's perspective of that whole patient, rather than looking at one particular condition. Comorbidity, on the other hand, looks at an index condition, and each condition in relation to it is considered comorbid. So you might say comorbidities of dementia. So dementia would be that index condition in the middle, and you could say comorbid conditions of that might be heart disease, diabetes, etc. So I use the word multimorbidity throughout my PhD, as I mostly focused on people with multiple chronic conditions rather than starting out with one particular illness that I was concerned about the comorbidities with. And multimorbidity has been increasingly researched in the last 40 years, but this graph was one I made for my thesis to show a brief search in Medline, the research database, for the term multimorbidity. And it's purely just looking for that word. As you can see, it increased vastly from 2005 to about 2010, and then again these data go up to the end of 2018. So the word itself is being used more often, although I'm sure that the state of having multiple chronic conditions was as important before. And I think in between the mid-80s and maybe late 90s, there was often a synonymous use of comorbidity and multimorbidity when people were really referring to multimorbidity. It's also becoming increasingly important in policy making and wide clinical guidelines. So you can see this nice guideline was published just after I started my PhD in 2016, so it was very much a topical subject. And the BMJ had this on their front cover. The image, I think, was later questioned as maybe perhaps a little ageist, but the image really just highlights how multimorbidity has been very widely publicised and talked about a lot in the BMJ recently, which will come on to why that worked out well for me too. And it's also been highlighted by this research report from the Academy of Medical Sciences released just 2 years ago, where they summarised all the research on multimorbidity to date and identified specific priorities for research in future. And we know from all this increasing research, I'm sure it's not a surprise to most of the audience, that having 2 or more chronic conditions, which is the usual definition of multimorbidity, is the norm in primary care. And I'll talk about this paper in The Lancet in 2012, which was published by Stuart Mercer and Bruce Guthrie, who have since moved to Edinburgh, and their team, which looked at over 1 million people in Scottish primary care and described the number of conditions that those people had. And a more recent paper using English GP data found that multimorbidity, so having 2 or more conditions, was present in everyone, in 27% of all adults aged over 18 in those data, which were from about 2016, and then it goes up significantly with age. So this is a graph from that Lancet paper from 2012, which if you've ever heard talk about multimorbidity before, you probably will have seen. It's used a lot. I think the striking thing here is how, as you can see, the darker colours represent having more conditions, and the age here is on the x-axis. You can see that obviously in younger ages, the majority of people are in this area with no disorders, but I think it's slightly surprising maybe when you first look at this that actually a lot of people in their 20s, 30s and 40s have more than 1 or 2 conditions. And at the commonly used arbitrary cutoff of 65 years for older age, you can see that the majority of people fall into the dark blue categories of having 2, 3, 4, 5 or more conditions. And looking at those 2 large epidemiology of multimorbidity papers highlighted that about 1/3 of people with multimorbidity have a mental illness as part of that multimorbidity. And that's very common, particularly among people in more socioeconomically deprived backgrounds. And that's often anxiety and depression, which is treated in primary care, but can also include substance use. And that I think there are two groups of people with multimorbidity: of the older people who have multiple physical conditions and mental illness. But there's also a younger group of more socioeconomically deprived people with various substance use and the physical consequences of those. And that Academy of Medical Sciences report from 2018 highlighted that mental health in multimorbidity was an area that had been under-researched to that point and should be a priority. And again, from that Lancet 2012 paper, this graph is of the number of physical conditions on the x-axis and the percentage of those patients who also had a mental health disorder, they've called it. And you can see here that the red line at the top is the most deprived group and the black line is the least deprived. So there's an increase there, that the more physical conditions you have, the higher proportion of those people have a mental illness, and that there's a striking difference between the least and most deprived socioeconomic groups, of up to 16% of the population. So then thinking back to what multimorbidity is, and as an epidemiologist, measurement is very important, definitions of what exactly we're talking about. So the NICE guideline that I mentioned earlier, and many other research looking at multimorbidity, specifies that it's simply defined as when somebody has 2 or more long-term health conditions with little other explanation on top of that. And that can be helpful when you're talking very broadly, as I have been doing with these broad figures. But when you're talking about individuals, it's important to think about exactly how you measure that. So the most common way of measuring multimorbidity is to count diseases. And the most common thing, this is most commonly done, about 50% of studies from a systematic review in 2012 found that the most common thing to do was just have a list of conditions and count from those. Obviously, it's very easy to do, either by asking the patient or looking at their medical records. And then you end up with either a continuous count, so a pseudo-continuous number from 0 to whatever your maximum number of conditions is, or a dichotomous one with a cutoff of 2 or more. So you can either have a continuous chronic condition count or a dichotomous multimobility around a predefined cutoff. However, this has some disadvantages. So it depends on the diseases that are in the list that you're counting from. Most studies have a list that they consider to be chronic conditions and then ask to count from that list. Some studies use every diagnosis in ICD-10. The studies on the best number of conditions to have in the list suggest that the most sensitive is between about 12 and 25, but I think a maximum I've seen is 115 possible conditions on the list. And it very much depends on the number of those diseases, because obviously the more conditions you have on that list that you're asking for 2 from, the more likely somebody is to have 2 of them. But also what exactly they are, and do you count the same thing multiple times? So do you say ischemic heart disease, which includes ever having had a stent? Do you include hypertension? Do you include diabetes as complications of diabetes as separate diagnoses from diabetes? So there are lots of different questions in there. It's also important to think about whether they're self-reported. So is this a cohort study where participants have reported their own conditions, or is it taken from medical records? Counting conditions purely from this list then assumes that those conditions have equal weight or equal importance for that person. And it might mean that sometimes we're not comparing the same thing between different people. So an alternative to counting conditions with just a count is to use indices. And these are methods of ranking the importance of conditions. Usually the most common way of doing it is to have a list of conditions again, and assigning each of the conditions a score or a weight, and that's usually based on their association with an outcome in an original study. And the most commonly used and most famous index you might have heard of is the Charlson Index, sometimes called the Charlson Comorbidity Index, although technically it's multimorbidity, which is extremely well cited with over 32,000 citations to date. And here it is. Here's the list of conditions that Mary Charlson used in this paper that came out just after I was born. You can see there are not a huge number of conditions, and that for each condition here, there are weights on the left-hand side. So for each condition that you have, you add up the weight for that condition to give a total score. I'll let you read those conditions and see if you think they're as relevant now as they might have been in 1987. I think the ulcer disease might not be considered to have an association with mortality now compared to how it did in 1987, but I haven't tested this out in a recent cohort. And I wonder if AIDS as well might have changed slightly with the antiretrovirals that are available much more widely now. And the other area that I think I would review if I was changing this would be cerebrovascular disease and dementia. And I wonder whether they would have the same weight of 1 when looking at mortality in our current cohorts. So having looked at that index and noticed there are a few things about it that could be changed, and appreciating that there is a huge number of ways of measuring multimobility and a huge number of indices, we looked for the previous systematic reviews on this topic, and actually there were 2 which were published in 2011 and 2012, and you'll remember from that graph of the huge number of publications on multimobility since then. So it felt like time to do a systematic review of this topic. So this is the paper that we had published in February this year in the BMJ. As I said, thanks to the BMJ's recent interest in multimobility. This is the Prismaflow chart, just to give a little illustration for what we did. This is Donica Mullen, who I think is in the audience, and Laura Gonzalez Saavedra, who are my co-reviewers looking at these over 7,000 records initially found, and we boiled it down to 35 studies in the end. And this infographic, inspired by Laura McWhirter, shows the main features that we found in these indices. So when we looked at all these 35 different ways of measuring multimobility, they had huge differences in what the information they included and how they were designed. And we separated them into the two key areas were the components of the index. So what went into it in the first place? Was it conditions? Was it drug counts? Was it measures? And these are the things that are in the middle here. We excluded pure disease counts from this review. So this is purely what we called indices, which by that we meant they had to be a count with a weighting or with additional information or extra things that weren't strictly a list of diagnoses, such as diagnostic clusters. So that, as I said, we separated this information into the components of the condition here in the middle, and then looked at the outcomes that the indices measured. And this is really important for when you're thinking about using an index, because if you're using, for example, the Charlson Index, which was originally designed to predict mortality, and you look at the weights that they used for conditions, those weights were designed based on their outcomes and mortality. So if you're using the Charlton Index to try and predict quality of life or somebody's likelihood of developing dementia, that's not what the index was designed for, so it's less likely to be useful. So we highlighted that it's really important to focus on what the outcomes were for the original index. And the most common ones were mortality, admission to hospital, healthcare use and healthcare costs, with other ones around the side here, including quality of life, which is another common one, but in a very different design of study to mortality. And mental health, I'll come on to, was a very small area, unfortunately. So after looking at these 35 different studies, assessing their quality in various different ways, we made this flow chart of our favourite 12 studies. And you can see here that I've summarised at the top to try and use it as a flow chart, that you stick in the available information at the top. So have you got diagnoses or drugs, and do you have additional information available? And then the outcomes that you're interested in here in this grey box is how to decide which index to use. You can see here that the outcomes of the studies that we recommended, the indices that we recommended based on their study design: mortality, quality of life, self-rated health, functioning, healthcare costs, mortality, admission. And there's only one that includes depression or any form of mental health measure, apart from quality of life, which is obviously important and very relevant. This one by Bayliss and colleagues was the only one that specifically mentioned depression. So this is published in 2005 by Elizabeth Bayliss in Health and Quality of Life Outcomes. It's since been named the Disease Burden Morbidity Assessment. And this index has 25 chronic conditions on the list, and they're weighted by participant or patient self-reported interference with daily activities. And the outcome, their main outcome of interest was quality of life, but they looked at various different ways of measuring that. And one of their outcomes was the depression screen from the behavioural risk factor surveillance system, which I think, from the information I could find, which isn't super clear, equates to either a PHQ-2 or a PHQ-8. And I've just added the numbers here of the people in the study. The study that they designed this assessment using only had 156 people in, but they were older, half and half men and women, and had multimobility in general. Compared to some of the other studies that we looked at, which had sort of hundreds of thousands of participants to make predictive models, this was quite small. So that was a recommendation that if you do want to use a multimobility index to predict quality of life and possibly depression, this would probably be the one to use. But unfortunately, there isn't really one that answers many of the questions we would have. And having recently been involved in discussions about the transition between general adult and old age psychiatry services in Lothian, none of the indices answer that question. So moving on to the second part of the talk, which is looking at polypharmacy. So again, polypharmacy is generally used as a word to mean taking several medications at once. And again, I spent a lot of time thinking about how best to measure it. The arbitrary cutoff used in a lot of studies of polypharmacy is 5 or more concurrent medications, counting as polypharmacy. There isn't a clear predictive value of that or particular reason why 5 is any worse or better than 4 or 6, but that's what is the general consensus, that polypharmacy is measured around, there's much less consensus that polypharmacy means 5 or more concurrent medications than there is about multimorbidity being 2 or more concurrent conditions. So unsurprisingly, multimorbidity usually coexists with polypharmacy, and a study from Sweden published in 2018 found that of people aged 65 years and over, 44% of those regularly took 5 or more drugs. And they also found that in people aged 75 years or over, the mean number of medicines per condition was 1.9. So it's not really a surprise that people who have 2 or more conditions would have 5 or more medications. This paper from Guthrie and colleagues in 2015 obviously had some of the same authors as that multimobility paper, so they very cleverly used a very similar design on the graph to show the number of medications, prescribed medicines by age, and again, general practice patients from 20 years and over. And you can see a very similar shape of the graph to the multimobility one. And the mean number of medicines among all adults was 4.4. So what about polypharmacy and mental health or mental illnesses? Well, there is evidence that polypharmacy is linked with dementia, probably because of the comorbidities, and also polypharmacy is often listed as a risk factor for delirium. But looking at these very large-scale health record studies, looking at polypharmacy, so those ones I was looking at, the Swedish ones, there's very little attention to mental health, mental disorders in those studies. So this felt like an area of interest for me. So I'm going to move on to talk about my analysis of some of the analysis I did in my PhD, which was of routinely collected NHS Scotland data. So thank you to the Information Services Division of NHS National Services Scotland, which has since been, this part of the NHS has since been taken over by Public Health Scotland. I had access to a very large data set of routinely collected prescribing data. So, and again, thank you very much to SciStar, who funded my PhD, for funding this rather expensive data extract. So I had data from everybody in Scotland who was aged 50 years and over, who received 1 or more prescription in the first quarter of 2009. And that started with community prescribing data. So part of that data set was that I had a list of every medicine that person received in that quarter, as well as a count of the number of unique medicines that they received in that quarter. That was linked to the CHI database. I received a completely anonymised edition, obviously, but the CHI database was important to link the patients to the different aspects of the data. It also gave me their deprivation. So again, I didn't get their postcodes, but I got a deprivation decile. So using the Scottish Index of Multiple Deprivation, which is based on postcode, I then was given where that person fell in the deciles of deprivation. The CHI database also provides a care home residence marker. It was also linked to records from the National Records of Scotland, who hold death certificate data for Scotland. And for that, I had the causes of death, both the primary cause of death and any additional cause of death, and the date of death. And I also had access to SMR, Scottish Morbidity Record 04, which is psychiatric inpatient data. And for the purposes of these analyses, I used the date of psychiatric admission, or time from the start to psychiatric admission. And I had the access to these data for 8.5 years follow-up, so between January 2019 and 2009 to June 2017, at quarterly intervals for the prescribing data. But for these analyses, I've only used baseline prescribing data, and all the outcomes were at any time that they occurred in the 8.5 years. So this huge data extract was provided to me by Idris, which is the arm of ISD Scotland who do data extracting and linking of the data sets. And I accessed it through the very secure Safe Haven through the FAR Institute at the time, but that's now changed as well. And I carried out all my analyses in R, because I had data from 1.2 million people that ended up in the final analysis set. And this is because, as I mentioned, I only had access to people who took one or more medicine or received one or more medicine. So there were around 2 million people in the original sample who were over 50 in Scotland, but 661,000 of those did not receive a medication prescription in that first quarter of 2009. And unfortunately, the way that the ages worked, age was completely essential to my analyses. So the age came from the prescription data. And because I didn't have the ages of those people, I couldn't include them in the analysis. So for all the following results, these are only people who took one or more medicine. And of those people, just over half of them were female. The mean age was 67.4 years. And the mean number of drugs taken or dispensed was nearly 5. And about 3.75% of those were resident in a care home, according to the care home residency marker, which is not completely accurate. This is a population pyramid of Scotland in January 2009, of people aged over 50 years, mostly for interest and to add some context to some of the following slides. So this is not people, this is everybody, including people who weren't on any medicines. And I think it's probably not much of a surprise for people who've seen population pyramids before that this is the baby boom of post-war people. And I think this section here of people who were in their late 80s in 2009 reflects probably a baby boom after the First World War, and possibly deaths from Spanish flu around that time as well. If anyone has any other suggestions, I'll be happy to hear them. I created a heat map of continuous drug count by age. So this is simply looking at the number of unique drugs that each individual was dispensed in that first quarter and their starting age on the x-axis. So when I say unique drugs, what I mean is that I received a list of every unique drug that person received in that quarter. So if they had a repeat prescription for, say, an antihypertensive, and they received it 3 times in that quarter, I would only see it once. But it also meant that if somebody had several medicines that they took regularly and then they had a prescription for an antibiotic, that was counted as well. And because of the sheer size of the data set, it wasn't possible to include specific lengths of prescriptions or time when they were started. For the purpose of these analyses, it's relatively crude. It's just the number of drugs they received in that quarter. So you can see on this map where the darker colours represent more frequency. So unsurprisingly, the younger patients had fewer unique drugs. And I think this section here reflects that baby boom spike that we saw in the previous slide. Here. I think that's there, so we've moved 90 degrees there. And this is just a heat map to look at the description, but I think you can probably convince yourself that as starting age in 2009 goes up, the number of unique drugs will also go up. I had to remove some people from this analysis because there were a small number of people with very extremes of age who would have been identifiable. So I also looked at, again, just for descriptive purposes, the unique drug count in that quarter according to deprivation. So this is the Scottish Index of Multiple Deprivation deciles of the people in the population in the sample studies. So these are the people who had at least one medicine. And you can see here, least deprived on the far right and most deprived on the far left, that it's quite convincing that the mean number of drugs was about 6 in people who in the most deprived decile compared to just over 4 in the least deprived decile. I also looked at psychotropic drug use. So to do this, I looked in the old style BNF at the different sections and looked at all the medications listed and categorized: antidepressant, anxiolytic or hypnotic, antipsychotic, dementia drugs, and mood stabilizers. I used a function in R to basically do the equivalent of Control F to find the strings of words, strings of drug names within those strings of medications. There obviously are some drugs here that would be used for multiple different indications, so antidepressants that are used for pain control, antipsychotics that don't necessarily mean people are psychotic, and mood stabilizers that are used for epilepsy as well. Again, I just have prescribing data, and these weren't linked to anything like GP diagnoses. So I have all these data can tell us is the people who were taking these drugs or were dispensed these drugs, not necessarily what the indication for prescription was. And I would highlight that actually that these data are from prescriptions that were then cashed in, so they're definitely dispensed records rather than what was prescribed by their GP. They're things that were actually picked up at a pharmacy. So from the whole population, in the people who received one or more drugs, about 25% took any psychotropic drug, and about 16% of people took an antidepressant, about 9% an anxiolytic or hypnotic, 3.4% an antipsychotic, a very small number of 0.7% with dementia drugs, and this is, remember, over 50s, and about 2% took mood stabilizers. In these descriptive data and in the analyses to follow, it's worth noting again that these were only from the initial the first quarter of 2009, and I'm hoping to look a bit more in detail for future analyses at what happened to the dementia drugs between 2009 and 2017, as I wonder if prescriptions increased for various reasons in that time. So this graph is looking at the percentage of people taking each subtype of psychotropic drug according to their age group. Again, purely for descriptive purposes, but it's interesting to see that the 80 plus age group had the highest percentages of taking psychotropic drugs, and unsurprisingly the dementia drugs here, which is this green bar, went up from a very small number in the 60 to 69 year olds, almost invisible in 50 to 59 year olds, and was clearly more prominent in 70 plus and then 80 plus as well. Antidepressants more commonly used in the younger age, and then slightly increased again in the older category. And again, whether that's to do with symptom control for other conditions as well as treatment of depression itself. And anxiolytics and hypnotics, again, much more common in the over 80s. Same with antipsychotics. And again, unfortunately, I can't link this to diagnoses, so we can't suggest whether this was all people with dementia who are receiving antipsychotics and anxiolytics or not. And this is a graph of psychotropic drug use according to deprivation decile. So again, purely looking at the percentage of patients in the cohort who received a psychotropic drug according to their deprivation. And again, the most deprived group, about 32% were taking any psychotropic drug, compared to about 20% of the least deprived group. So on to the analysis questions, having moved on for our descriptive epidemiology there. Broadly speaking, my questions was polypharmacy, or an increasing use of multiple medicines associated with mental disorders in these routinely collected linked data. And you'll see that unfortunately mental disorders was difficult to pin down in these data, but I did what I could. So first of all, I looked at, is polypharmacy or increasing drug use associated with a mental disorder on the death certificate? So to think about that, I'll show you first about mortality, all-cause mortality, and you can see that in that whole population, so 1.2 million people, followed up over 8.5 years, 27.4% of those people died in that period. And of the people who died, around 10% had a mental disorder listed as the primary cause, and about 19% had the mental disorder listed as any cause on the death certificate. So not directly contributing to the death, but may have contributed to it in a secondary way. And the mean age at death was probably unsurprisingly older for women at 81.9 years compared to men of 78.2 years. And I looked at all-cause mortality to contextualise the analyses where I specifically looked at mental disorders. So and this is using Cox proportional hazards rate models, with each additional drug, the hazard ratio for mortality in 8.5 years was 1.089, with a relatively small confidence interval because of the huge data set. And that was adjusted for age, gender, deprivation index, and care home status. So that's with each additional drug, there was about a 9% increased risk of dying in that 8.5-year period. And when you adjusted for those same covariates, but adding in psychotropic drug use as a covariate, the hazard ratio decreased slightly, but still was statistically significant and was around an 8% increased risk. And because of the those results were looking at each individual drug and how adding one to the number of drugs affected the mortality. But we were also interested in whether there were specific numbers of drugs that had any more associations with mortality or some of the other outcomes. So this is looking at again, Cox proportional hazards model, but for each number of medicines from 1 up to 20 plus. And this is the graph for all-cause mortality according to a drug count. And you can see that it's quite clear that compared to people on taking one medicine, which is this reference here, with the dotted line suggesting that it's the same as taking one medicine, it's quite clear that with each additional increase, there's a clearer association with mortality. And on these graphs, I'll explain further in the next two that the grey bars, the bars are confidence intervals and the blobs are the hazard ratio, and the grey ones are adjusted for starting age, gender, deprivation, and whether or not the person lived in a care home, and the yellow ones have an additional covariate of whether the person took a psychotropic drug, which seems less important here in the all-cause mortality. So looking at the mortality outcomes as they related to mental disorders, I've broken it down here just to look at what exactly those mental disorders were. And again, it's perhaps not unsurprising that dementia or mild cognitive impairment, which, although mild cognitive impairment was much less common, but I've added it into dementia for the purposes of summarising it, was by far the most common primary cause of death of all the mental disorders, recorded on 9.4% of death certificates as the primary cause and 17% as any cause. Again, I think the recording of dementia on death certificates has increased probably over this period. I looked at just that whole 8.5-year period without adjusting for the time of death or time of diagnosis. So again, that's something to look at in future. But you can see that the other mental disorders were much less likely to be recorded on death certificates with very small numbers. And even delirium, which I think probably is much more common than it is recorded on death certificates. So again, looking at this question now, we've contextualised it. For mortality with any mental disorder on the death certificate, with each additional drug, the hazard ratio for mortality in that 8.5-year period was 1.033. So there's about a 3% increased risk of dying with a mental disorder for each additional drug taken in that period. But when you added in psychotropic drug use as a covariate, the hazard ratio decreased and the confidence interval suggested that this was much less significant. And that p-value in this data set would not be consistent with that being significant or convincing. And this graph shows a bit more information about this. So again, this is hazard ratios of the number of medicines dispensed along the x-axis with 1 as the reference, and the outcome of dying with a mental disorder recorded on the death certificate. The grey bars again are adjusted for age, gender, deprivation, care home status. And I think if you look just at those, that you'd see that every number above 1 is significantly associated with an increased risk of dying with a mental disorder on your death certificate. However, when you look at the yellow bars, which is adding in psychotropic drug status, so yes or no, is the person on one or more psychotropic drugs, if you add that in as a covariate, then you can see that after about 13 drugs, the confidence interval lines start to cross the 1, which is the comparison with the reference, and suggest that that's much less likely to be significant. And what that might tell us is that psychotropic drug use might somehow explain that association. We'll come on to that shortly. So the next question was, how is polypharmacy or increasing drug use linked to hospital admissions for psychiatric hospitals? So there were 23,700 admissions to psychiatric hospital during this, first admission. So this is patients who were admitted at least once to a psychiatric hospital. That's about 2% of the sample. I counted just that first admission, the time to the first admission. And the mean age at admission for all over 50s was 72.9 years. So for this, with each additional drug, the hazard ratios for admission to psychiatric hospital was 1.06, so again a 6% increased risk of admission to psychiatric hospital with each additional drug. But again, when psychotropic drug use was added as a covariate, that association didn't look significant. And again, so that's just with adding each individual drug continuously. But a similar graph here to the last ones, looking at the hazard ratios for each number of drugs with psychiatric admission as the outcome. And again, when the yellow bars are when psychotropic drug use was added as a covariate, and you can see that after 10, the association seems to be less significant, and again may suggest that that's the main explanatory factor. I don't think I can think of many people who you would admit to psychiatric hospital who weren't on a psychotropic drug to start with. And the final question, which was an additional one, was moving away from polypharmacy, but looking at these data that I had and seeing how many people were taking psychotropic drugs, was taking a psychotropic drug at all associated with mortality over that time. And this is grouping the patients by whether or not they took one or more psychotropic drug in that first period, that first quarter of 2009. And the hazard ratio for mortality there was 1.262, so a 26% increased risk of death in that period. And that was adjusted for all the drugs, total number of drugs, age, gender, care home status and deprivation. And I think, again, it's probably heavily confounded by indication, but it's very interesting to think of whether that's a mark, and you can just use it as a marker for having a psychiatric diagnosis rather than the psychotropic drugs themselves, but that people who were on these drugs have increased risk of dying from any cause. So in conclusion from these analyses, polypharmacy, taking 5 or more medicines, is very common, and the data from Scotland support those data I presented earlier from Sweden, that 46% of these over 50s take 5 or more drugs of people who take at least one. And I think the main factor in many of the answers was that having a pre-existing psychiatric diagnosis was likely crucial, because having a psychotropic prescription was could be used as a marker of having a psychiatric diagnosis, and that when you started adding that into analyses, it explained a lot of the association. These data can only answer very specific questions, can't tell us anything about causality, obviously, and some of the other limitations of them are that the mental health outcomes available in routinely collected data are, as you saw, rather crude. So we have only what's on a death certificate, and I think most people filling in a death certificate aren't going to start going through a patient's psychiatric notes to find all the diagnoses they've ever had, and also even if they did, they might not be considered relevant to the death. Psychiatric admission is a clear, yes, you have definitely been admitted to psychiatric hospital. I haven't looked here at the diagnosis associated with that admission, but again, that's something that can be done in future. There's no way of finding out about people who have diagnoses who weren't admitted to hospital, or anything about symptoms or anything like that. As I said, this is only from people who received one or more medicine, and we couldn't include the people who didn't take any. Unfortunately, Scottish routinely collected data at this level does not include general practice data yet, so it's not possible to adjust for the number of diagnoses. And from these analyses, all I can say is that taking a certain number of medicines is associated with these outcomes, not that the medicines themselves cause the outcomes, just that may be a marker of multimorbidity, not that it can be used to define multimorbidity on its own, but that polypharmacy is usually a marker that somebody has multiple conditions. And the other thing is that there are very few covariates collected, so ethnicity is very poorly recorded and isn't on the data that I used were from things like prescriptions, and obviously ethnicity isn't recorded on your prescription. So the summary answer to my summary question of whether polypharmacy was associated with mental disorders in these data was the classic epidemiologist answer of it depends. And where I'm going to go with this work in future is that I've got lots of other things to do with it. I've got this huge data set. And from these analyses, I only looked at that initial quarter and followed people up depending on their baseline number of drugs. But I'm going to be looking for the next few years. I've received a lectureship from the Chief Scientist's Office to start in August, where I'll be looking at how the number of drugs changes over time, as well as whether or not people stop taking psychotropic drugs. I'll look at different combinations of drugs. I'm hoping to look more specifically at diagnoses, including depression and dementia. And I'm also going to conduct parallel analyses in the Lothian birth cohort. And to be more specific about diagnoses, I'm going to add in linked data from SMR, Scottish Morbidity Record outpatient data, where hopefully people have been accurately recording dementia diagnoses and depression diagnoses in outpatient clinics. These are just two headlines of other bits of research I did in my PhD, where I tried to complement the huge, relatively crude data from NHS Scotland with much smaller data sets with very refined detailed levels of information at participant level, so including EPAD and Prevent Dementia. And I'd like to say thanks very much to my PhD supervisors, who are delighted to have their photos here, and to my lay contributor, Mary Nisbet, who I met throughout my PhD to talk about how multimorbidity and polypharmacy was important to her and how it affected her life. Thank you very much.
Thanks very much, Lucy. That was a great talk, and I'm sure there'll be some questions. Just